Welcome everybody to this webinar brought to you by the Global Remission Coalition, the first of a series of regular webinars we'll be bringing you on this topic. Thank you very much for joining. My name is Neil Bettridge. I'm the Senior Director for the Global Alliance for Patient Access, GAFPA, but more relevant to today, the Chair of the Global Remission Coalition. And as you can see, the topic today is to bring to you new evidence supporting the pursuit of remission in inflammatory rheumatic conditions specifically, although we believe there are a lot of issues covered here that would have application in other chronic inflammatory conditions too. We are recording this webinar in the usual way just to help us take a record of everything that we cover, and we will be through in 30 minutes or so. And indeed, here's the agenda for today. So after my brief introduction, I'll be bringing you a presentation care of Marieke Heisen from Patvocates, and Marieke was the lead researcher on the evidence glossary update and indeed last year's original edition of the evidence glossary, after which we'll pass to Professor Tony Woolf, who chairs the GRC's Medical Advisory Council, looking at what these messages mean in action. Action here referring to the sort of advocacy actions that many of you in patient organisations and other groups take in support of these remission-related policy messages. And then we hope to allow some time for question, answer and wrap up. So the objective of today is really to take a slightly deeper dive into the evidence glossary. Some of you may have been present at the launch of this at EULAR this year in June in Barcelona. But because we have Marieke with us especially, there's an opportunity to get into some of the findings there in a bit more detail. And the real objective here ultimately is that this will enable you to be hopefully even more effective in your advocacy work at national, regional and global level through having more of a feeling and understanding of the content and how it could help you with your advocacy work. So very briefly, let's take a quick look at the structure of the Global Remission Coalition, because we only launched it in May of this year at the World Health Assembly. And it's here to inform stakeholders, both internally and facing out externally, about the value of pursuing remission, why it delivers benefits to patients through quality of life outcomes and to society for cost savings and other reasons. We will act as the platform to bring together stakeholders, both members and others like today, in order to discuss shared priorities, to get the messages right so that everybody is content. We have the correct messages to take forward to policymakers, and to consider how we can support you guys doing your advocacy work at all levels around the world. And we hope to go on over the period, over the longer term, developing resources which will help you to do all of that, and also to help highlight the importance of pursuing remission in chronic inflammatory diseases. So moving on briefly to the membership, we launched in May with around, I think, 35 members. We've got 9 or so more joined since, which is fantastic, from right across the world, so truly global. Many are patient organisations from not only rheumatic disease, but other inflammatory areas such as skin and bowel disease. And apart from the steering committee of patient advocates, which are helping to inform the direction of the coalition, we also have a medical advisory council. And as I mentioned, Professor Woolf is chair of that. So with no further ado, we'll move on. Please, throughout this, do put your questions into the Q&A, not the chat, the Q&A, please. And those are some of the things we'll try to pick up at the end today. Just very briefly, the journey here really began by the development of this white paper when we first brought stakeholders together about 18 months ago. So this is really the basis of the policy messages we've developed since. Let's take a very quick look at what they are, the priorities there. They are these 6, it's a work in progress, but these are the 6 key policy areas we're highlighting at the moment around early intervention, which we know is so important in inflammatory diseases, and trying to ensure that best practice clinical guidelines are actually implemented or perhaps even adapted and refreshed in some parts of the world where that's necessary, to make sure that individual patients are aware of their choices around services and treatments with good validated information, Public awareness is tremendously important here too, of course, to try and get people to present early to their primary care practitioners in order to then get a timely referral on, to make sure in number, but also more appropriate more often. And at the heart of all this is the person. So that's all from me. I'm going to pass to Marieke now. And please, Marieke, it would be great to hear you shine a light on some of the hard work you did doing the research that led to the glossary update this year. Thank you for joining us.
Oh, Julia, can you do it again, the remote? Thank you very much, Neil. Pleasure to be here today. I think I cannot yet advance the slide. No.
You should be able to.
Yeah, I clicked too late. Or you can advance the slide, that's fine as well.
Yeah, maybe Julia, if you...
So what is the evidence glossary? The evidence glossary is equipping you with evidence based on 90 plus sources from around the globe. If you go next. It's a collection of summarized recent research on, firstly, inflammatory rheumatic conditions, because it all starts with remission and not just knowing what it technically is, but really understanding what it means to patients, to how having less pain and bringing a halt to the disease have a transformative impact on patients' lives, their social lives, employment, their autonomy, financial stability, and mental health. And this is why every patient should have the right to pursue remission and why that pursuit is anchored in clinical guidelines. Now, the combination of a rising prevalence across the globe and a debilitating impact are why policymakers should act with urgency. Over 18 million people currently live with rheumatoid arthritis and around 65 million with SPA. And if we look at the larger family of musculoskeletal conditions, we are looking at 1.5 billion people worldwide, with MSK conditions being the main cause of chronic pain, which is also highlighted in the glossary. Oh, I'm not sure who's now driving. Can you go next?
That's the next one.
Yeah, next, please. In Europe, by 2030, up to 50% of working age people could be diagnosed with a chronic MSK condition. Now, secondly, second bullet on this slide is actually we collected evidence on the value of pursuing remission. It is more likely to reach remission when action is taken early. And Professor Woolf will talk more about that. And the benefits of remission as shown here are ample, both for the individual as on a societal level, leading to higher work participation and productivity, lower medical care expenditures, and improved outcomes. We've also gathered proven solutions and inspiring examples from different countries, and Professor Woolf will also touch upon these. Next. Now, what does the evidence glossary do for you? And you see here the same 6 points as Neil highlighted. Next, please. So it's actually point 3 that is empowering you, and we're speaking to the patient advocates among the audience, to use this in your country to reach local policymakers with these messages. Next. Lastly, I'd like to highlight one aspect that stood out to me, and that's the impact of early retirement, both on the personal and a societal level. When people are no longer burdened by the debilitating effect of inflammatory rheumatic conditions, they can participate more fully in the workforce. In contrast, those who do not achieve remission may find themselves caught in a cycle of disability benefits and unemployment. This not only affects their financial independence and also often their mental health, but also places strain on public assistance programs. Next. So you can look at loss of productivity in 3 different ways, and it's measured in 3 ways. Productivity impairment, so you're working with lower productivity because you're ill. You're missing work days because you're being ill, work days lost, or work disability, which actually means early retirement because you cannot work at all anymore. Now, work disability is actually the main contributor to loss of productivity, but it is often not captured or not fully captured in, for instance, economic models for health technology assessment and not factored in by decision makers. There may be no evidence on it. Next. However, when early retirement is factored in, indirect costs, which are mostly non-medical, make up a much larger share of total cost than direct costs, which are mostly medical. So this is a very important contributor. Now, what you can see here is that productivity impairment, if you compare people in remission versus those not in remission, is 8 to 12% versus 30 to 46%. That's the top left. So it's a large difference. And work days lost, there's even a difference of 75%. Now, if we look at loss of income on average due to work disability, there's actually a difference of 5,000 euros per year between somebody in remission versus somebody not in remission. And this is only the loss of income part. Next, please. In most countries, the national healthcare budget and the disability rate unemployment benefits, they are politically dealt with separately. So it's often a tough decision to invest in health, to actually have savings when it comes to unemployment benefits. Well, the case is clear. If you go to the next slide. This is an example from the UK where they calculated if they would invest 11 million pounds in health, they would actually save 31 million in welfare costs. That is why I want to conclude with the following. Next slide. What societies do not spend on health, on prevention and on ability, they will spend on disability. Now I'll hand the floor over to Professor Woolf.
Thank you very much, Marieke. I'm just testing whether I have control of my slides. So if you could advance the slides, please. So you've heard about the glossary and what it is. And just to cover some of those points a bit more, the key message is that rheumatic muscular conditions are debilitating. They're a major global health challenge, and inflammatory rheumatic conditions are part of the larger family of MSK conditions, which affect over 1.5 billion people worldwide and are the leading cause of disability in many, if not most, countries. And the burden is rising. This is because of aging populations, risk factors, lifestyles, risk factors increasing, people moving into cities and being less physically active. So it's an enormous burden within which inflammatory rheumatic conditions are a very major component. And if we go to the next slide, these conditions are characterized, as you well know, by pain, and they prevent people doing what they need to do and want to do. Although they increase in impact in older people, and some of these conditions become more common in older people, it's important that everyone appreciates they affect all ages. Sometimes policymakers think this is just something of old age and inevitable, and even the public often think that as well, and that's a message we have to change. They're also, as you're aware, progressive diseases unless effectively managed. And the impact of pain and impaired function is far-reaching on quality of life and well-being, and the functional impairments mean people lose independence and leave the labour market, as Marieke was telling us, with economic impact both on the individual and their families and also on society. And 1 in 3 people with RA stop work within 5 years of diagnosis. That's a pretty atrocious statistic. Next. But we know that acting early prevents long-term disability. The advances in treatment options, particularly for inflammatory rheumatic diseases, has been enormous in the last few decades. I've seen radical changes since I was training, where we had very limited therapeutic agents, to now where we have biologics and other interventions which really can achieve remission, get the disease under control. But the problem is that damage is not reversible, so you have to start early. And therefore, based on the evidence, there's multiple guidelines highlighting the need for early diagnosis and treatment to achieve remission, or at least a low disease state, as soon as possible. The problem is that too few people are aware of this and present to their doctor late, and also the doctors aren't always aware of it and do not act quickly. So an audit a few years ago in the UK showed that 50 to 75% of people waited for over 3 months before they sought help, and then they often saw their primary care doctor 4 times before being referred to a specialist. Therefore, it can take 9 months from symptom onset to treatment, and that is missed opportunity, which has to be dealt with because the damage can be irreversible. So how do we get to early diagnosis? We have to raise awareness of the benefits of early diagnosis and remission amongst the public, so they don't think of it as being inevitable consequence of aging. Medical education, so GPs know the need for urgent action, and all other health professionals need to have a more positive attitude about these conditions and realise that they need urgent action. National strategies need to be developed regarding best practices and implementation of early diagnosis and intervention, including agreed upon standards of care and quality indicators. And for example, in Poland, a national programme was set up specifically for the prevention and early detection of RA and implemented by education of medical staff and patients and a screening tool. So there are programmes which are taking this forward, but these are not widespread enough. Next. So our goal has to be remission. And it's not just our goal, everyone's goal has to be remission. We know for other life-threatening diseases like cancer, it's all about remission, but we don't hear that language enough around inflammatory musculoskeletal conditions. Next. So what does remission mean? Well, from a rheumatologist, it can be sometimes quite a clinical concept of a low disease state where the blood tests are normal, the MRI scans are normal, and the inflammation scores are low. But for people with these diseases, remission means much more. It's a transformation in their daily lives. Less pain, less fatigue, and a return to normal routines. Being able to do what you want to, when you want to, in the way you want to do it, almost forgetting you have a disease. And many of you may have experienced personally a disease-modifying drug achieving remission, or know of other people who have and seen that transformation. Next. So the other thing is remission triggers a whole chain of events, positive events, that really affect people throughout their lives. Less pain and fatigue leads to freedom to move, which leads to improved physical ability, more daily activities and daily achievements, building a sense of success and self-confidence, supporting social interaction, finding a job, doing well at work, social life and employment boosts autonomy, independence, financial stability, and mental health, and also by keeping mobile and active, good general health. So it all leads to a more fulfilling and higher quality of life. And we have to get people to understand that along with the data. Because as highlighted, there's less pain and fatigue, improved mental status, and greater work productivity. Next. We've heard about the economics of work, but also remission reduces medical care expenditure with less hospitalizations, less joint surgeries, and less radiographs. Previously, before we had this possibility, but lots of hospitals had beds for people with inflammatory rheumatic diseases where they would be for many days, if not many weeks. And now there are very few dedicated beds because it's not necessary if you are getting people into remission. Next. So we have to make sure that proven solutions are implemented, early diagnosis and intervention. That's through recognition and appropriate referral. That will lead to healthier working lives and also people being enabled to manage their conditions and ensuring that the treatment meets their needs, but also their preferences, person-centered care. Next. So you've seen this before, the advocacy priorities. All these are necessary to address the burden of inflammatory rheumatic conditions and ensure that people have access to remission. Next. From my point of view, at the policy level, the key things are that health systems need to ensure access to early diagnosis and referral to enable early intervention. the pathways have to be there. It must be easy for someone to be seen, and then when recognized that they probably have an inflammatory disease, referred to an expert who can confirm diagnosis and introduce disease-suppressing therapy to achieve remission. Also, to maintain that remission, health systems must ensure access to affordable long-term treatment to achieve and maintain remission. And that is also a barrier in many countries where the drug cost for long-term conditions falls on the patient and is often outside the insurance system. Next slide. So the key message for all of us in this coalition is to advocate for remission. And to support that, there are these products. You've heard about the report on the value of achieving remission, the evidence glossary. There's also a fast fact sheet. There's also an opinion piece myself and colleague did to support your cases. So we need to take this forward, and you need to work with your policymakers arguing the case for remission. Next. Thank you.
Thank you very much, Tony. And thank you also, Marieke, for really illuminating presentations. Just building on what you were saying towards the end there, Tony, and very much speaking as a patient advocate myself for many years now, I think we all know that we need to take to policymakers not only rational arguments about the burden and the solutions, we also need to take a very human factor, the impact on individuals and families and so on. But we also need the data, we also need the evidence. And that's very much what the evidence glossary is there to do, to help illustrate both some of the burden, the problematic aspects of not achieving remission, but also to highlight good practice, what works, and to really encourage policymakers to build their policies out of the evidence. So thank you both very much for that. We've got time for, we've got a few minutes now for questions, so please keep them coming into the Q&A. Maybe say who you are as well if you're leaving a question there, just having a look at issues. Marieke, one thing that has come out of the glossary and people have commented on is, and you mentioned this, Tony, that these inflammatory rheumatic diseases tend to get, in the wider societal view, lumped together as arthritis, and at the wider societal level, that often suggests to people older age. But Marieke, we know from the glossary of last year and this, that actually the evidence tells us something quite different, right?
Yeah, and I think, I mean, if Tony touched upon that, there's also more and more evidence coming out of how it affects younger people. I mean, we also talked about, the wider impact of MSK conditions, just to make clear, like, as a family of diseases, it is really a large burden on society. But also the actually what you need to do, for instance, also like adjustments at work, they're very different for inflammatory conditions. It's not like lower back pain. So there also has to be a clear distinction on, what works in these inflammatory conditions is different from other MSK conditions.
Absolutely. Yeah, thank you. And Tony, you, towards the end of your presentation, gave one example of a barrier that we might face from policymakers as we conduct advocacy along these lines, which is obviously around cost, simply the cost of services and treatments. But from your experience, what other barriers should we be mindful of? I mean, if we take into policymakers something whereby what we're asking for doesn't actually require additional expenditure and in fact saves money for the healthcare system and society, why wouldn't policymakers take this and run with it? What do you think the barriers are that we need to be thinking about in going forward?
So I think the different types of barriers. So one is, and Marieke referred to this, is the finance departments are separate to the health departments, and finance considers health a cost to the system and not an investment to help people be more productive. And that is one of the things which needs to be joined up. So in the UK, our government a few years ago created a joint work and health unit, and I've been involved with them, and that really has radically changed things because it means they are all working together, recognizing that people who are unable to work is waste. And it's at the individual level, people should have the right to be able to be economically active and do what they want to do and need to do and interact socially through work and be financially, gain from that. So it's actually bringing that together is one of the key things, and getting into the data more about the long-term consequences of people with these conditions in terms of work loss and society costs. Because a lot of the health technology assessments look at more short-term benefits and costs. So that's something, but also it's one of the challenges just to motivate people. For some reason or other, which is hard to explain, people don't spontaneously recognize the importance of pain-free mobility and function. And we've got to motivate people. The data is there. You can't argue against it. The enormous burden, the costs, the potential benefits which modern therapies can offer. But how do we motivate people? And this is where I think we need those stories really highlighting the 24 out of 7 impact that these conditions have on people's lives. And that is, as I've said, it's all avoidable in this day and age. So I think that is something. So it's motivating them and then showing them the data to close the deal. Because everything gets signed off by a finance director.
Right, exactly. And I know, you gave the example of the UK, and I know one of the compelling arguments in the UK to encourage successfully actually policymakers to do more for rheumatic and musculoskeletal diseases was savings around employment and employability. And to your comment in the Q&A, Lisa from Canada, thanks for that. Absolutely, the focus on preventing deterioration in the first place in the workplace, but also getting people back to work after onset of an inflammatory condition is absolutely crucial here. First and foremost to the individual, but secondly, because of the benefits it brings not only to that employer, but to the society, right? Because you keep people paying their taxes rather than claiming disability benefits. And so the wins are multiple here. Just one quick question, Tony, on differences between lower and higher income countries. I know you've done a lot of work at the global level. Could you just in a few seconds almost characterize things we might need to be mindful of going forward as we work across 5 continents on this topic?
Yes, and I also noticed a question from Edmund in a way relating to that. What is the biggest barrier? You need the data and you need some local data. I think you've got to have that there, but it's really getting in there and having a conversation with the policymakers. I've been doing some work recently in Tanzania, meeting the policymakers there, and they very rapidly admit that their focus has been very much on infectious diseases, childhood diseases, nutrition. And then when they get to NCDs, it's largely just cancer and heart disease. And they're suddenly becoming aware they've got aging populations, lots of people with chronic pain, lots of people with disability, and they are realizing they need to refocus and need to have some solutions. So I think we are now at a stage of an opportunity, but you have to get in there because we always, for some reason, find they don't spontaneously think of musculoskeletal health as being a priority area. It's almost taken for granted. So I think it's getting there, and also it's got to be evidence and stories. That means people with lived experience working with people with learnt experience who can convey that story.
Absolutely. Great. Well done, Tony. Well said. Well, absolutely. We're almost at time. It's flown by. So let's just share a couple of final slides with you. Please do take a look or another look at the glossary. We hope it's going to be a living tool that will help support advocacy along the lines we've discussed. And there's the QR code if you want to go direct into it now and take a look at it. We will be ensuring that this webinar is available as a podcast on the Global Remission Coalition website afterwards. And on this slide, you can see the various ways that you can connect with the GRC. So please do. We're really just at the beginning. This initial work stream on rheumatic diseases is really creating a lot of enthusiasm, as you've seen from the membership and the way it's grown already. We're going to continue to build that and hopefully and certainly plan to incorporate other chronic inflammatory conditions in this work going forward, because there's a big job to be done across a range of diseases here. My final word is to say thank you. Thank you to the sponsors who make this work possible, which at the moment is AbbVie and Merck MSD. But most of all, thank you to Tony and to Marieke for your presentation, for Julia for all the fantastic support, and most of all for you today for joining us. Do take a look at the podcast and do please share it widely, because we want to get these messages out there. Thank you ever so much for joining. See you next time.